Hello and welcome to our monthly webinar series on Asian health, brought to you by the Center for Asian Health Research and Education, CARE for short, and the Stanford Health Library. My name is Bryant Lin, and I am one of the co-directors of the Center for Asian Health Research and Education. I'm really happy to bring to you a wonderful talk by my brilliant colleague, Dr. Latha Palaniappan, who is co-director with me of the center. Dr. Palaniappan will be talking today about how do your genes affect your medication response. Dr. Palaniappan is an internist and clinical researcher. Her research has focused on the study of diverse populations, chronic disease, and prevention. Dr. Palaniappan specifically seeks to address the gap in knowledge of health in Asian subgroups and other understudied racial ethnic minorities. During her time at the Palo Alto Medical Foundation, as the medical director of clinical research, she led an organization-wide initiative to collect patient race, ethnicity, and language information, enabling PAMF researchers to conduct disparities research using electronic health records. She was co-founder of Prana, a South Asian wellness program. Her current work examines the clinical effectiveness of structured physical activity programs for diabetes management, as well as the best exercise regimens for normal weight diabetics. She was recently awarded a Mid-Career Investigator Award by the National Institutes of Health to provide mentoring to junior clinical investigators in the conduct of patient-oriented research. She's currently working on implementation of evidence-based genetic and pharmacogenetic testing in primary care clinics as the scientific director of precision genomics and pharmacogenomics in primary care. She is the faculty co-director of the Stanford Biobank, designed to accelerate translatable scientific discoveries. She co-founded the Center for Asian Health Research and Education, CARE, at Stanford in 2018. Please join me in welcoming Dr. Latha Palaniappan.
Thank you, Dr. Lin, and thank you everyone who's joining us today. We have about 100 registered participants, and we have the Q&A function open. So if anyone has any questions, please put them in the Q&A, and Dr. Lin will present them at the end of the talk. So today we're going to talk about how do your genes affect your medication response. And our goal at Stanford is to provide the right dose of the right drug at the right time for every patient. And we are really at the forefront and cutting edge of doing this at Stanford Medicine. Next slide. So this is inspired by all of our patients who at one time or another, and I'll show you the data on the first 50 patients in the human-wide study today, that where over 90% of people had something in their genome that was helpful to them in terms of their medication dosing and prescribing. And so this is a patient that we had in the human-wide study that we presented at the Big Data and Precision Health Conference. And she came to us with an important question prior to getting surgery, asking, why doesn't Vicodin work for me? And we looked at her genome and we were able to assess that her CYP2D6 enzyme was not a variant that processed Vicodin appropriately. And we were able to tell her prior to getting shoulder surgery that she should use alternatives like morphine as opposed to Vicodin, which is a prodrug and needs to be metabolized by CYP2D6 into morphine. So this is an example of the kind of changes that we can make for personalized prescribing. The next slide. So what is pharmacogenomics? So all of us as physicians and patients know that not all people respond to the benefits and side effects of medications the same way. And pharmacogenomics are inherited the same way as our hair color or eye color, but it's not something that we sit around at the Thanksgiving table and talk about. How did you respond to Vicodin or clopidogrel or warfarin, any number of the medicines that I'll talk about today. So pharmacogenomics is the study of how your genes can influence your response to medications. Your genetic variations can determine how a medication is absorbed, metabolized, and processed by your body, and how this may interact with other medications or supplements. So we refer to this as drug-drug and drug-drug gene interactions, in addition to drug-gene interactions. Next slide. So why pharmacogenomics? We want to save patients money on medications, so we want to find the right medication for the patient without trying to switch medications, and it takes the guesswork for us as physicians out of prescribing treatments. And importantly, and I'll give an example of this upcoming in the talk, we really want to reduce the side effects of medications so people don't have adverse events with medications, which sometimes occurs. Next slide. So we have observed in population-based studies that patients with the same condition, after undergoing DNA profiling, we can identify good responders, people who don't respond, and those with bad effects. The good news is that those with bad side effects and people who don't respond well are a relative minority of the population. So 5 to 10% of the population at maximum for each drug. Next slide. So when we talk about drug metabolism, we use the acronym ADME. ADME stands for A for absorption. So this is whether you put the drug in your mouth. So and how it is absorbed in your GI tract. D is for distribution, how your heart pumps this medication around to your blood, and whether it's hydrophilic and might stay in the plasma, or hydrophobic or store in the fat. And then metabolism, which is mostly done in the liver. So 90% of our drugs are metabolized in the liver, and most of these are metabolized in the cytochrome P450 system. So you can see that cartoon on the right for cytochrome P450. And E is for excretion. Most of our drugs are excreted in our kidneys. A few are excreted in our gut through bile, but most are excreted through kidneys. And most of the enzymes that we know about right now with regard to drug metabolism are focused in the liver. So you'll see a lot of the enzymes start with CYP, and that stands for cytochrome P450. Next slide. So we in the Bay Area have a diverse population, and I'll talk a little bit more about that in upcoming slides. And so it's especially important for us to understand how medications work in diverse populations. And we have several examples of where drugs don't work as well in diverse populations, or different drugs should be used. And that raises our clinical radar and antenna to look out for other differences that we can find in order to increase precision prescribing. Next slide. So this is just an example of some of the pharmacogenetic differences that we've found specifically with regard to Asian populations, which are quite common in the Bay Area. 1/3 of the Bay Area is Asian. And I'll go deeper into cardiology drugs, including cholesterol lowering drugs such as Crestor, warfarin, which is a anti-clotting drug, which is often prescribed for people with arrhythmias such as atrial fibrillation. And then Plavix, which is also a drug that is used to prevent clotting after cardiac events. There's also differences in oncology drugs, particularly tamoxifen, which is metabolized by CYP2D6, similar to the Vicodin example, which I just told you about, and also HIV medications and antifungals, so infectious disease and rheumatology drugs as well. Next slide. So there are many factors that can contribute to the observed race ethnic difference. There are some physiologic differences, which we'll discuss, pathophysiologic differences, genetic differences, and pharmacogenetic differences, which we'll discuss today. There may be environmental factors, for instance, how much alcohol you drink can induce liver enzymes, as well as smoking, caffeine. These can all lead to differential metabolism of drugs, as well as idiosyncratic reactions. And all of these can interact and be quite multifactorial in terms of determining interracial, ethnic differences in exposure and or response to drugs. Next slide. So there are many differences that we have learned by studying diverse populations. There's differences in biomarker prevalence, and we will see an example of this with factor V Leiden mutation, which is more common in those of European ancestry. Differences in safety and efficacy. So with asthma, we've discovered differences in metabolism of beta agonists in studying African ancestry patients, in part due to two genetic variations. I'll talk a little bit more about CYP2C19 variants and metabolism and how they're different in East Asian versus South Asian ancestry. Differences in HLA-B1502, which affect metabolism of carbamazepine and leads to a very severe skin reaction with people with variants in HLA-B1502. And carbamazepine is prescribed for seizure disorders. And there's also differences in understanding pathways. So we have new scientific discoveries with regard to factor II deficiency, which is a rare bleeding disorder with a higher prevalence among Latin populations, Latinx populations. So study of diverse populations in general helps us understand disease pathophysiology, discover new treatments, and personalized care. So we will talk about all of these examples today. Next slide. So this is how I describe drug metabolism to my patients. So most people, 90% of people, are normal metabolizers for most of the enzymes that we're going to discuss today. And so this means traffic is flowing normally in the liver. And if you think of normal traffic as being 2 lanes on the highway, most people are normal metabolizers. And this is why when FDA is approving drugs, they're looking at a majority of the population that this drug is working well. So these are normal metabolizers. Next slide. There are some people that are intermediate metabolizers. So they have 1 lane on the highway. And this is okay if you are maybe using only 1 drug that is metabolized by this pathway. But in some cases, you might be using 2 drugs, and then there's a traffic jam if you're an intermediate metabolizer. So this is why it's important to consider not only drug-gene interactions, but also drug-drug-gene interactions. Next slide. Then we have people who are rapid or ultra metabolizers. So these are people who have 3 lanes on the highway. And this is important to consider when we have prodrugs that need to be metabolized into the active form. And if people, for instance, are rapid metabolizers of Vicodin, they might get some of the side effects like respiratory depression, but the pain relief goes by very quickly. And so these people might be asking for more and more pain relief through Vicodin, and they might be mislabeled as drug abusers, but really they're rapid metabolizers, and they're metabolizing the coating very fast and not getting pain relief that lasts a long time, as you would see with normal metabolizers. Next slide. And then there are people with poor metabolism. So these are people who have no lanes on the highway. And in those cases, we need to be very careful about giving drugs that are metabolized through these pathways. Next slide. So I'm going to give you an example first of treatment of high cholesterol and cardiovascular disease in Asian populations. Next slide. So Crestor is a very commonly used drug to lower cholesterol. I'm currently working on the Clinical Pharmacology Implementation Consortium guidelines for cholesterol. And this is one of the drugs that we have special consideration. Next slide. Because Crestor is normally prescribed at 10 milligrams, but the FDA label warns not to do this for Asians in particular. Next. Because of differences in P1B1 in the the liver that is transcribed by an enzyme called SLC01B1. And variants in this have Asians metabolize this drug more slowly. Next slide. So for Asians, Crestor at a lower dose is recommended, 5 milligrams in general, but we want to watch out for generalizing this term Asians because, next slide, this has only been studied in Chinese and Koreans, but this is extrapolated to all Asian subgroups. And we'll see some examples later of where Asian subgroups differ widely. And so you can't take data from one Asian subgroup and extrapolate it to another. Next slide. Now I'm going to go through an example for warfarin. So warfarin is a drug that we give to prevent clotting. And there are differences in CYP2C9, next slide, that recommend decreased dosing for Chinese, Japanese, and Korean patients. Next slide. There's also differences in VCORC-C1, which recommend increased dosing for Blacks, African Americans, and Asian populations. So it's important to look at a patient's CYP2C9 variant as well as the VCORC-C1. So in real life, what we do is we take all of these variants and we put them into a warfarin dosing algorithm to decide what the initial dose of warfarin should be. Next slide. The third example that I'm going to use for cardiovascular disease is Plavix or clopidogrel. So this is a medication that's commonly prescribed after someone has a cardiac event, maybe a stent is placed to prevent clotting of the stent. Next slide. So there are differences in the CYP2C19 enzyme, which is also in the liver, part of the cytochrome P450 system. And clopidogrel is one of those drugs that I mentioned that's a prodrug that is, as I mentioned with the ADME, it's absorbed in the intestine. And next slide. The differences in CYP2C19 in the liver determine the amount of active metabolite that can be used to prevent platelet aggregation and block ADP binding. Next slide. And there are differences in this cytochrome P450 enzyme, CYP2C19, wherein there's a loss of function mutation and increased risk of clotting in Japanese patients, Korean patients, and Chinese patients, and a gain of function mutation, which is related to increased risk of bleeding in Asian Indian patients. And this is quite common. So 1 in 4 Japanese patients, 1 in 7 Korean patients, 1 in 10 Chinese patients, 1 in 4 Asian Indian patients. And these variants are not seen almost at all in Caucasian patients, so less than 1% of Caucasian patients, and very few African American patients as well. Next slide. CYP1A2, so this is a enzyme that metabolizes a drug that we all commonly take, caffeine. Next slide. And CYP1A2 can be induced by cigarette smoking. Next slide. And we find that this interaction in Japanese smokers, they have a variant, STAR1C, that decreases caffeine metabolism with smoking. Next slide. And a different variant in Caucasian smokers, STAR1F, increases caffeine metabolism. So we have a lot to learn about race ethnicity, the different variants, and how drugs are metabolized based on these variants. Next slide. So these are some results from our human-wide study. So these were 50 patients in a pilot study funded by the Dean's Office, looking at if pharmacogenomics would be useful for most patients who are coming through primary care. So here we looked at the workhorse enzymes, CYP2D6, CYP2C19, CYP2C9. So together, these enzymes metabolize about 50 to 60% of all drugs. And SLC01B1, so this is the one that metabolizes statins, which is a commonly used drug. And 91% of patients had at least one genotype in one of these that was considered to be high risk. And we are defining a high-risk genotype as one in which a change in dose or medication should be considered. So you can see on the y-axis, we have the number of patients, and on the x-axis, those who had no high-risk genotypes, one high-risk genotype, two high-risk genotypes, 3 or 4. And so you can see we have a nice bell curve there. And there's very few people that have nothing to worry about in terms of these workhorse enzymes, but it's still reassuring to know that all of the medications that we might prescribe that we currently have data on, that there would be no changes in dosage or prescribing. Next slide. So this is an example that we often talk about in the Center for Asian Health Research and Education, and Dr. Lin speaks so eloquently about a patient of his who had an HLA-B5801 variant, which is much more common in Asian patients. So you can see the estimate in Caucasians and Hispanics versus African Americans versus Asians. And the risk in Asians is almost 10 times as high in having this variant. And the relative risk of having allopurinol associated, so allopurinol is a medication that we use for gout, severe cutaneous, which means skin-related adverse reactions. And you can see that both African Americans and Asians have a much higher, so 3 times the relative risk of allopurinol associated skin reactions. Next slide. So let's take a deeper dive into Asians in the Bay Area. So Asians make up 60% of the world's population, 6% of the US population, and 30% of the Bay Area. And we have a microcosm of the world in the Bay Area. So excellent representation of every Asian subgroup in the world is represented in the Bay Area. Next slide. And yet less than 1%, to be precise, 0.17% of NIH funding goes to Asian-related research. Next slide. Asians are also underrepresented in clinical trials. So as I mentioned, Asians make up 60% of the world's population, as you can see in the pie chart on the right, and 12% of those that participate in global clinical trials. So these are the trials that we use to bring drugs to market, and Asians are quite underrepresented in these global clinical trials. Next slide. So decisions around Asian health are made using mainly non-Asian data. And as you can see from the couple of examples that I presented so far, and the examples that I'll present going forward on diverse populations in general, this is a problem. And I'm currently working on a grant application actually to increase the genetic diversity that we have in the human cell atlas. Because most, and we'll see a slide on this, most of the genetic data is non-diverse as well. Next slide. So let's take an example in other diverse populations. So I'll take blood clotting disorders in European and Latinx populations as our next example. Next slide. So factor V Leiden mutation. So factor V is part of our clotting cascade. Next slide. And we need factor V in order to clot. And sometimes there's a mutation, which is most common in European ancestry. And this is actually named after a town in the Netherlands, Leiden. And so people are heterozygous, about 3 to 8% of the population. And those are homozygous as 1 in 5,000. And this represents very severe clotting disorders among European populations. Next slide. There's also a factor II deficiency, next slide, that is also part of the coagulation cascade. And you can see where factor II fits in. This is called prothrombin deficiency. Next slide. And this is generally present in 1 in 2 million people, so very rare bleeding disorder, but we see a higher incidence among Latino populations. So this is something that we might want to screen for more in the diverse populations that we have in the Bay Area. Next slide. So what can we do as physicians and patients as we move forward? And one thing that I always say in my talks is that I predict all of us in 10 years will have pharmacogenetic testing. It is getting more and more affordable, and we're having more and more information that we can utilize to do precision prescribing. Next slide. So at Stanford, we are fortunate to have really the father of this field, Russ Altman, and Dr. Russ Altman taught me pharmacogenomics about 5 years ago when we started the clinic in pharmacogenomics in our concierge and executive health program. And so this is a database that culls all of the scientific literature and provides information on 647 drugs and 133 pathways, provides dosing guidelines. And this takes information from all areas of the world, including the Dutch Pharmacogenomics Working Group, and compiles data also on drug labels from around the world. Next slide. And then we have specifically, and this is part of the consortium that I'm working on for the statin guidelines, the Clinical Pharmacogenetics Implementation Consortium. So this tells us as physicians, when we see these pharmacogenetic variants, when do we have strong evidence to change dosing or prescribing, and when is the evidence a little bit weaker, and helps us identify areas that we need more evidence. Next slide. So this is an example of a report that we get at Stanford in our pharmacogenetics consultations. Next slide. So you can see some of the enzymes that we talked about already today: CYP2D6, CYP2C19, VCORT-C1, SLC01B1, CYP1A2. And these enzymes can tell us about 400 different drugs. So we look at these 25 different areas of the genome, these variants, and it can tell us about 400 drugs, including commonly used cardiac drugs, antidepressants, anticoagulants, statins, antivirals, opioids, and also over-the-counter analgesics. Next slide. So this goes back to our study in human-wide, where we did pharmacogenetics consultation on 50 patients. So on the y-axis, you see the number of recommendations that we made, and on the x-axis, the different classes of drugs in which they were made. So psychiatric drugs, statins, isoniazid, opioids, clopidogrel, antihypertensive medications. And we made either preemptive recommendations, so that is a recommendation made before the person was actually on the drug, but they had a high likelihood of being on the drug given their medical and family history. So for instance, if people had a family history of cardiovascular disease, we made a preemptive recommendation on statins because most people who have a family history of cardiovascular disease at some point in their life do go on these cholesterol lowering drugs. And then reactive recommendations are those in which people are already on the drugs, and then we're making recommendations to lower the dose or change the drug. Next slide. And then looking at our phenotypic results based on select genes. So on the left-hand side, you see the pilot study, the human-wide pilot study, and the right-hand side, the general population level estimates for these different enzymes: CYP2D6, CYP2C19, CYP2C9, and SLC01B1. And you can see, in general, our pilot population was less likely to have normal metabolism. And this may be due to the fact that our population is more diverse. So you can see that the referent group, the larger populations that have been studied, and we'll take a look at how diverse groups are underrepresented in what we deem to be the population prevalence estimates, are mostly Caucasian. And in our pilot study, as you know, by the Bay Area, only 50% Caucasian, so more diversity represented. And there may be more variants that are concerning in terms of drug metabolism in diverse populations. Next slide. And we did analyze our Stanford primary care patients. So we looked at electronic health records of 45,000, over 45,000 patients, almost 50,000 patients. And we saw that based on their current drug profiles and the population prevalence of these variants, that about 10% of our population was deemed to be at high genetic risk. About 10 to 40%, about 15% is at medium genetic risk. So 10 to 40% likelihood of having to change a medication or change the dose of the medication. 30% is at low genetic risk, and 50% have no current genetic risk. And this is for reactive recommendations. So in terms of preemptive recommendations, I also say it would be great to have everyone have pharmacogenetic testing at birth, because then we have many more years to utilize this information in our prescribing. And at one point or another in our lives, we are prescribed drugs that can be informed by the current pharmacogenetic variants that we're studying. Next slide. So now let's talk about pharmacogenomics for the underserved. So it's very important as we move forward with the cutting edge of medicine that we do not leave people behind. And often when we incorporate new technologies, we increase the digital and technology divide. So let's take a look at some of the data here. Next slide. So as I mentioned, genomics is failing on diversity. So on the left-hand pie chart, you see in 2009, we had about 1.7 million samples in 373 genetic studies, and 96% of those were of European ancestry. Fast forward to 2016, and we have many more studies, 2,511 studies, 35 million samples, so many more samples, and yet we haven't increased the diversity as much as we could have. And this is something that we're working on at Stanford. I'm submitting a grant for this now. As we mentioned, those of Asian and non-European ancestry are very underrepresented in genomics. And that gives us less information on pharmacogenomics as well. So this is important going forward to have more diverse populations participate in the research so we can do better precision prescribing for all of our patients. Next slide. This is a slide on telehealth use by race ethnicity, which is not exactly the pharmacogenomics, but this may give us a clue as to where we might find disparities in pharmacogenomics. And we are writing a grant on pharmacogenomics specifically to partner with our federally qualified healthcare centers so that we can bring pharmacogenetics technology to underserved populations. So you can see here that telehealth use in general, about 50% have no use of telehealth. And this is overrepresented in Asian and Hispanic populations who are more likely to not use telehealth. Next slide. And when we consider new technological innovations, we have to remember that some people, some groups are using smartphones only. And for instance, the pharmacogenomic software that we use is web-based and is not available through phones. So as we think about new pharmacogenomics technologies, we should think about ones that can be used by populations who are primarily smartphone users. And you can see there are vast race ethnic differences in terms of the number of portion of households with broadband internet. So 65% of Hispanic households versus 71% of Black households versus 80% of white households have broadband internet. Next slide. So not enough is known about pharmacogenomic testing in minority groups to assess whether they are more or less likely to use pharmacogenetic testing. Though we at Stanford are committed to bringing pharmacogenomic testing equally to all race, ethnic, minority groups and those with varying levels of socioeconomic status, so that we can improve health of all of our populations equally. Next slide. And it's important for us to remember that equality is not the same as equity. So I show this cartoon in my population health classes to the first year medical students, and equality means that you're giving everyone an equal amount. So let's say pharmacogenetic testing costs $100 for everybody. That would be equality, but equity is giving more to groups that need more. So perhaps for some groups that are underserved, we're actually making pharmacogenetic testing free or low cost and charging $100 to the people who can afford to pay. So this would ensure more equitable distribution of these new technologies, including pharmacogenetic testing. And our goal is to reduce health disparities, which we've identified in many different diseases, including diabetes, cardiovascular disease, hypertension. And it is my hope that pharmacogenomics can bring us closer to reducing health disparities and bringing health equity to everyone. Next slide. So we have done case reports on interpreting these variants in current pharmacogenetic testing. And this is important for consumers because there's many companies that offer direct-to-consumer pharmacogenetic testing. And we found through a patient who came to us with outside pharmacogenetic testing compared to the pharmacogenetic testing that was done in our vetted Stanford lab, that there was differences in variant interpretation where the outside lab called the variant as intermediate metabolizer when she was actually a normal metabolizer for one of the very large enzyme groups, which created sort of undue anxiety and frustration. So it's very important as we move forward to use guidelines that are vetted by scientists from around the world, like the Clinical Pharmacology Implementation Consortium, as opposed to relying on individual companies to do their own variant interpretation. So I encourage you to look at this if you are to undergo pharmacogenetic testing yourself, because it can be a Tower of Babel, and it's important to have a good interpreter for this information. Next slide. So where do we go with pharmacogenomics 2.0? So as I mentioned, pharmacogenetic testing can provide information on the medications you currently take and potential medications you may need to take in the future. So that's preemptive recommendations. So this can ensure you take the right medications at the right dose for you. And this is just some information on pharmacogenetic testing at Stanford Healthcare. So this is just a saliva test, similar to a COVID test many of you have maybe taken, which you mail in. And then you have a consultation with a pharmacogenetics expert who at this time is me or Dr. Russ Altman. And so there's the phone number to contact, and you can also look us up on the internet if you just put in Stanford pharmacogenomics and personalized wellness. You'll find this information on pharmacogenetic testing. Next slide. So with that, I will stop, and we have plenty of time for questions. So I'm looking forward to hearing from the audience.
Great. Thank you so much for a wonderful talk, Dr. Palaniappan. We have many, many questions. I don't think we'll be able to get to all of them, but let me cherry pick a few. Early question from an anonymous attendee. How readily available is one's genomic information, and how often is this currently used when medications are prescribed?
So we are still in the early days. If you want to think of it as Model T and not yet a Tesla in terms of incorporating pharmacogenetic testing into our daily interactions. But I do think that this is the costs are decreasing rapidly. So currently, the cost of pharmacogenetic testing at Stanford is about $1,200 for the test as well as the interpretation. But I anticipate in a decade that these costs will be around the $100 range. And this then will be something that more people can use. So still early days of the automobile, though, with this technology. Commodore 64, not Mac.
Excellent. And then a practical question from Eileen Yang. I think you touched on this at least at Stanford, but perhaps you can generalize. How do you, please advise how to request the testing of pharmacogenetics, genomics? Do we need referring or prescription from a physician? So I think you touched on this at Stanford. How does one go about this outside of Stanford? And you talked about reliability and of the other issues of concern for kind of less reputable places. How do we go about this?
So excellent question. So and thank you, Chloe Salas, for putting the pharmacogenomic testing link at Stanford, so you can self-refer. And we looked at the landscape of all the pharmacogenetic testing companies about 4 years ago, and I'm continually reevaluating this and have most recently done so in the last month. But we were looking for companies that adhered most to these clinical pharmacology implementation consortium guidelines. So these are guidelines that a bunch of experts come together and decide how the variants should be classified and interpreted and what drug changes should be made. So we looked for companies who adhere to the CPIC guidelines, and we looked for companies that considered not only drug-gene interactions, but drug-drug gene interactions for those intermediate metabolizers, and also because people use more than one drug. So it's important to consider if they're going to get traffic jams with the intermediate metabolizers. And also we picked a company, which is Invitae, just so people know what company we use at Stanford currently, that also incorporates nutraceuticals and herbal medications, because many of our patients take traditional Asian medicines, alternative medications like St. John's wort for depression. And so it's important to be able to incorporate those in terms of understanding our pharmacogenetic response.
And you touched on this a little bit, but Sarah Choi asks, and a very practical question, do insurance companies cover pharmacogenomic testing?
So just last summer, Medicare changed the coverage guidelines. They're still quite complex. So for instance, I told you we do a panel with 25 different variants that tells us about 400 drugs. So current insurance guidelines are only to test for one of those variants for one of the drugs. So it's the amount of reimbursement is not the same as what the costs are currently for the commercially available panels, because we're doing more panel testing, and that makes more economic sense than, for instance, for every drug that you take to submit a saliva sample and just to test one variant at a time, cost-wise, it makes sense to test more variants. And the current Medicare guidelines are allowing for, if you're taking 2 or 3 of the medications, to do panel testing. Though, again, we're at very early days, just taking baby steps with insurance reimbursement. I'm talking in the next week or 2 with our hospitalist colleagues to talk about whether this is something that is good to do for pain control in the hospital. For instance, when you're admitted with a surgery, one of the limitations is also the turnaround time. So the turnaround time for pharmacogenetic testing currently is about 2 weeks. So we need to decrease that turnaround time to make it really useful for inpatient medicine.
And what about private insurance? You mentioned Medicare. Private insurance similar, or is it all over the map?
So it's all over the map, and there are some insurers that are allowing for a reimbursement for depression, particularly so multi-gene panels for depression, um, and that is something that we hope to start at Stanford as we near the beginning of the end of the pandemic. So more to come this summer.
And people can, do people often use their HSA, FSA dollars for this?
Yes, you can use HSA, FSA dollars for this.
Great. Well, just moving back a little bit more to the science, Ramohan Rao, I apologize if I mess up your name, has many, many questions. Why don't we go to the first two? Do pharmacogenomic tests involve analysis of SNPs, specific gene mutations, or protein modifications? Why don't you take that first one, and then we'll go to the second one, or his or her second.
Okay, so yes, it does measure SNPs, single nucleotide polymorphisms, and I'll point out that most of these SNPs have been identified in Caucasian populations. So we do need more diverse populations to be in these pharmacogenetic trials, so we can identify less common SNPs in European populations, which may be more common in Asian or other populations, as we saw with the example with the HLAs and allopurinol. So we have a long, long way to go. Though there are other researchers at Stanford. So at the last Stanford Health Library talk, we had Dr. Eric Gross and Dr. Chihung Chen talking about a breath test for CYP2 C19 polymorphisms. So this is a very exciting way that at the point of care that we would be able to understand phenotypes of the patients that we're treating, and not only the genotypes. So this is something that we'll be able to incorporate more going forward.
And second question was, looking into the future, will pharmacogenomic tests be carried out prior to giving medications preemptively, or post-medication after noting deleterious effects, or maybe lack of response? What's the good in the workflow of medicine, clinical medicine? Where does pharmacogenomics fit in?
Well, as I said, I hope it's at birth. So when our babies are born, maybe a little bit of saliva, getting the pharmacogenetic testing and having that on file. So we're working with companies now to have it integrated with the electronic health record so that we can get what I call POP alerts, so point of prescription alerts. So currently I go through and I think of, based on their family history and their medical history, which of these 400 drugs might my patient encounter in their lifetime? And then I give them specific recommendations on these things, and it is in their medical record, and they would have to search in the future if they're being prescribed, for instance, a proton pump inhibitor in the future, what variant might influence that. However, we hope that in the future, if someone puts in omeprazole, it might say, oh, give this person a lower dose because they might have more side effects given their cytochrome P450 variant. So again, we're doing studies on this for large healthy populations. So far, pharmacogenomics has mostly been studied on and shown to be cost effective on people who are very sick, discharged from the hospital, and looking at outcomes like readmission or adverse events or drug-drug and drug-drug gene interactions in people who are very sick, taking many medications. So it's more cost effective in those populations. But in large primary care populations, I think it will take longer amounts of time for these small wins to add up over a lifetime to be cost effective.
Great. There were a couple of questions on pharmacogenomics, I guess genomics, maybe not pharmaco, depending on, I guess, how you include vaccines, and the COVID vaccines. Are there any research and genetic response to vaccines, specifically COVID vaccines?
So we talked about this at another talk that I was at. So there has been making headlines some thought that in a synthetic data set, so again, this is, basically just a data set that is not people, but based on different MHC and HLA polymorphisms, so major histocompatibility complex and human leukocyte antigen differences across race ethnicities, that there might be lower vaccine efficacy. And this is work that Dr. Lin and I have done together. However, when you look at the actual clinical trial data, there's a hint that there might be lower vaccine efficacy, but the sample sizes were simply too small to conclusively show that vaccine efficacy is different in race ethnic minority groups. That said, this is something that we're actively studying, and Dr. Lin and I have a collaboration with Sutter, and we're looking at Sutter data to see, and Stanford data to see if now that most people are vaccinated, if we might see more people of specific race ethnic populations who, despite vaccination, still get COVID, and the jury is still out on that. But I will emphasize that the headlines you see are on synthetic data and not real populations, hinting at less efficacy in racial ethnic minority groups.
Great, fantastic. I know this is, I picked another question because I know it's something you're interested in. What effect does being biracial or multi-ethnic have on one's pharmacogenomics?
So that is an excellent question. So I often quote the statistic that 1 out of 7 babies born now are mixed race, so 2 or more race ethnicities. And this is something that we need to study going forward. And we do have active studies in this area looking at mixed race populations at CARE, at the Center for Asian Health Research and Education. And of mixed race populations, many are mixed race of Asian heritage and ancestry. So in terms of pharmacogenomics, it's important to study variance in specific race ethnic groups so we understand mixed race variants better. And then we are hoping that as pharmacogenomics becomes more and more prevalent, that we won't need to look at race ethnicity as a shorthand for instance, if you might have a CYP2C19 polymorphism, which is more common in Japanese or Chinese patients, that we will actually be able to test. So not to say, oh, 1 in 4 Chinese patients have this polymorphism, but actually we can test to see if you are that 1 in 4 or 3 in 4 who don't have the polymorphism. So as testing becomes more cost effective, we'll be able to get at the heart of the matter more quickly.
Great, fantastic. Of course, being in Silicon Valley, we cannot, we have to have a question about machine learning from Woo-Sung James Kim. Are there machine learning studies regarding pharmacogenomics that are promising?
So machine learning, we are doing to find, which populations might benefit most from most treatments. And we are just at the beginning of trying to do gene by environment studies. So combining information that we have, for instance, on a person's age, their race ethnicity, their comorbidities, other drugs that they're on. And I'm involved in this mostly with diabetes medications, the newer diabetes medications, SGLT2 inhibitors and GLP-1 receptor antagonists. And we are looking at clinical trial data as well as observational data to determine groups that benefit most from these drugs in terms of hemoglobin A1C lowering as well as cardiovascular benefit. And as we are gaining more facility with putting together complex data sets, we are using machine learning and other artificial intelligence methods, including neural networks and deep learning to try to get at better disease prediction, prevention, and more personalized treatment.
Great. I'm going to paraphrase this question. Pharmacogenomics are so important and they've been lacking in clinical trials. Should all clinical trials be required to have pharmacogenomic testing as part of the trial?
Um, I'm biased, but my answer would be yes. And actually, I'm working with a group at Harvard, the Multi-Regional Clinical Trials Initiative, and we are working with pharmaceutical groups to one, increase diversity in clinical trials, and number two, understand the diversity in those clinical trials at the pharmacogenomics level. And, and this, there's understandably some hesitation in this, and that you need larger and larger sample sizes to understand treatment differences in subpopulations. But as we innovate in terms of lowering barriers to participation in clinical trials, lowering costs for clinical trials, as the COVID clinical trials have so beautifully taught us. We can be better about amassing large sample sizes and diverse samples in short amount of time. So again, we are looking at the future of medicine with pharmacogenetic testing. And I'm confident that everyone on this call will have pharmacogenetic testing in their lifetimes. It's coming.
Great. We've got 2 minutes left, so let's broaden and lead off the answer you just gave. You mentioned increasing participation in clinical trials several times so far. From Janine Sung, what communication approaches might lead, and maybe other approaches, might lead to greater participation in research from diverse communities? So how do we solve the problem of participation from diverse communities that aren't currently participating in clinical research?
Well, I want to thank you for that great question, and I want to do a quick shout out to Janine Sung, who's part of our new master's program in big data and clinical informatics. She's also the director of the Stanford Biobank. So thank you, Janine, for that question. And this is something that we've talked a lot about in the biobank. How do we engage diverse participants? And part of that is having good community engagement. So I want to give a little shout out to Nina Lee at the Center for Asian Health Research and Education. So she's been marvelous in terms of connecting with Asian communities in particular, and diverse communities in general, and providing bi-directional interaction. So these talks are an excellent example of that. And other content that we're able to share, so that patients are more aware of the benefits of participating in clinical research and are more likely to participate. And also going to where patients are, so not expecting them to come to our academic centers, but there have been great studies, for instance, for hypertension reduction in barbershops in African American populations. So going to where our patients are. I've done interventions in temples and mosques and churches in the Bay Area. We also did an intervention in taxi drivers at San Francisco airport, because they often waited 2 hours to grab a fare. And we did physical activity interventions there. So going to where our patients are, as opposed to asking them to come to us, is important. And then also lowering barriers to participation. And this is something that the biobank aims to do. So, not having to spend hours signing an informed consent and making a separate visit to get a blood drawn, but being able to piggyback on to a clinical visit, doing an informed consent electronically through your phone or your iPad. And then just drawing an extra tube of blood when you're getting your blood drawn anyway, instead of creating more friction for patients. So lowering participant burden is also important. So thank you. And then, and I hope someone can post on the chat the Stanford Research Registry. So this is a registry which we've started for all race ethnic groups. at Stanford to increase diversity in clinical trials. And you go in, you put in your information, some basic demographic information, and some information about your health conditions and risks. And this way, researchers can reach out to you quickly if you have a condition of interest for the research study. So please register for the research registry as well.
And does that include the biobank? Are they one of the audience members asked about whether the biobank is collecting specimens still?
Yes, the biobank is collecting specimens, and if you register at the research registry, we will be able to reach out to you for the biobank.
Fantastic. Well, thank you so much, Dr. Palaniappan, for a wonderful talk. Many, many more questions, but we don't have enough time today. But please encourage the audience to join our future events, our future webinars. Our next big care event will be a concert at 5:30 this Thursday celebrating Asian grandmothers, followed by a panel celebrating generations of Asian women featuring Fiona Ma, the highest-ranking Asian political official in the state of California, and many, many others. Please register at medmuse, medmuse.stanford.edu. Really appreciate all of your attention today, and please join us for future events and future talks in the coming months. Thank you so much.
Thank you.